Good evening, everyone. Welcome to this, our final winter webinar for this winter webinar series. I'm Lucy Meehan. I'm one of the radiologists at VetCT. It gives me great pleasure to introduce Dr. Jonathan Dixon of Rainbow Equine Hospital, who's going to talk to us about, in the world of foot MRI, has CT got a place? Jonathan has had experience of working with a number of CT systems, including the Hallmark standing CT system that is currently available. Hallmark have very kindly sponsored this lecture in conjunction with being produced by VetCT. So as I said, Jonathan is currently head of imaging at the Rainbow Equine Hospital. He has previously worked at the RVC in London and has a wealth of experience in all types of equine diagnostic imaging, as well as with CT. So without further ado, I will let Jonathan carry on with his talk. If anyone has any questions, please don't hesitate to put those in the Q&A box. I will be monitoring the Q&A box through the talk. We will have some time for questions at the end, so I will leave those until the end, but please feel free to pop those in the box as we go along. Thank you very much. I'll leave you with Jonathan.
Good evening, everybody, and or good morning, depending on whereabouts in the world you're joining us from. Thank you for joining us for this webinar regarding MRI and CT of the equine foot. We'll try and answer this tricky question and see if we can fathom our way through this together. I'd like to echo Lucy's sentiment and thank Hallmark and VetCT for sponsoring and organising these series of webinars. They've been really intuitive and interesting from some great speakers, and hopefully we'll muddle our way through an interesting topic today, and you'll enjoy this one as well. So I'm going to take us right back to basics when we're thinking about answering this question and pose a simple question of, firstly, why do we consider doing cross-sectional imaging at all? There's a couple of case examples here of conditions that hopefully many of you out there will be well familiar with. A horse with radiographic evidence of laminitis on the left, another horse on the right with an ultrasound examination of a superficial digital flexor tendon mid-substance or core lesion. And clearly certain horses out there, many horses out there, will have diagnoses which can be made with conventional imaging. However, it's not uncommon for more than one type of pathology or one type of injury to be present within the distal limb, and certainly the hoof capsule in particular limits our ability with certain techniques such as ultrasound to image so far further down into the foot without significant obstacle. And radiographically, there are just simply a large number of conditions, as we'll come to shortly, that will not be visible within this really common region of a cause of lameness. So there's plenty of rationale to consider other ways of looking at that region. Why do we do it? Well, I think everyone would quite widely, hopefully, accept that an early diagnosis or leading to early intervention within a disease process or an injury would potentially, though not always, potentially allow us to identify an injury or lesion as a mild or moderate severity of pathology, and potentially that might be early, it might not be in that disease process. The aim being, as veterinarians, we can try and prognosticate, understand that injury, and potentially intervene. The ultimate goal being to improve the outcome for the patient, to potentially lead to a happy owner, though that might be the hardest objective of the whole lot. And it's really this stage of prognosticating and potentially intervening only when we know exactly what is going on that lets us choose a path, if we can intervene at all, between adapting or recovering from the injury or the lesion presence, or allowing that process to continue to deteriorate. And really it's that adaptation recovery phase where we can choose to make a change and potentially try and influence the ultimate outcome of having a happy owner. So, we must know exactly what's going on in order to guide a sensible pathway through this and navigate that process. And perhaps this is a good way to start this, a lateral medial radiograph of a foot with a horse that's got an abnormal navicular bone. It's got an abnormal navicular bone in a number of ways: the shape, the opacity, the loss of margination between the palmar compact bone and the spongiosa. But how really, thoroughly can we examine the entirety of the podotrochlear apparatus? And ultimately, I'm sure, we're all aware and on the same page here that the reality of MRI is that it opened our eyes to understanding a lot more about what's going on in the equine digit, and particularly relating to the soft tissues. And right now, I think in large parts of the world, we're able to almost to some degree banish or abolish the term navicular syndrome and become more specific with our diagnosis, whether that is truly a navicular bone injury or whether that's a soft tissue structure within the remainder of the podotrochlear apparatus. And again, understanding that has implications for the prognosis, the treatment, the outcome, and managing those clients' expectations. And a big part of opening our eyes to understanding that it has been a nice leap forward from a personnel and a team safety. The avoidance of ionizing radiation with the use of MRI has been a really helpful leap forward to image these horses in great detail. Two examples here: a standing MRI system, the one produced by Hallmark on the left, and a low field MRI image here of an equine fetlock. An alternative system here, a high field MRI 1.5 Tesla MRI system, and then a similar high field MRI image of the distal metacarpal region of a different horse. And these bits of equipment have various trade-offs, benefits, and disadvantages, but they really have broadened our world. The obvious downside of both of these systems for our clients, and this won't come as any surprise, is that these systems are expensive, they have an impact and obviously a cost, and that has potentially moved them outside of the realm of some of our clients. There are many horses that require an MRI. Nowadays they are widely accessible for a lot. So that's been a really good start. When we then moved on and really focused, standing MRI, in my opinion, certainly in Western Europe, in the UK, has taken us a step further. Just an example of a horse here having a standing MRI of a foot. This is a classic Yorkshire UK horse, but the standing MRI systems, such as depicted here for imaging the level of the carpus, have really facilitated imaging quite large regions of the limb in the standing horse, and that really has moved things on quite nicely. Now, today we're going to focus on the foot, and so when we think about foot MRI, I've just highlighted a number of anatomical structures or lesions that we might identify relatively frequently on a foot MRI examination. And I've really sort of looked to say, okay, of these common findings or common causes of foot lameness, which of those have really been enhanced by our ability to do MRI, either standing or under general anesthesia? And those are arrowed in red. It's clearly the soft tissue lesions, primarily, so deep digital flexor tendinopathy and desmopathy or desmitis of the coffin joint collateral ligaments. We get a lot more information about synovial distension, and that affects the distal interphalangeal joint and navicular bursa in the foot region with MRI, though you can get some information dorsally and palmally from ultrasound. But particularly, these bone marrow lesions, otherwise known as bone edema-like lesions, bone contusions, bone bruises, we're all referring to ultimately the same type of process. They're really a diagnosis that's quite specific to MRI at the moment. There are a number of lesions that we would expect to pick up other ways, and I've indicated the navicular bone region pathology, including distal border fragmentation, varying all the way through to again, fluid, intraosseous fluid or osteonecrosis, as something that potentially we can image with radiographs, maybe CT as well, and maybe MRI for some factors, particularly intraosseous fluid is something we can only see on MRI. And then hoof capsule lesions, really, I've left those and osteoarthritis potentially open to lots of different modalities as our ways of examining them. Radiographs have been proven for a long time to be quite sensitive for osteoarthritic change. Articular cartilage I've put at the bottom because I think we'll circle back to this a little bit later, but articular cartilage in standing systems or low field systems in general proves a little bit of a challenge, in part due to the fact that horses are weight-bearing standing scans and compressing those cartilage layers, and in part due to simply the thickness of them and the ability of the imaging systems to resolve those structures. So it's not really a golden ticket system, but probably MRI has been a real game changer in equine distal limb orthopedics. And we see an awful lot of lesions. So I've just selected a variety of foot lesions here, some of which are relatively common, such as a longitudinal tear here in the deep digital flexor tendon. Another example here, a mid-substance lesion within this enlarged deep flexor tendon lobe, through to distal border navicular bone fragments, enthesiopathies and fragmentation of the proximal border associated with the collateral-sesamoidean ligament. This is an example here of a dorsal middle phalanx or P2 bone marrow lesion. We can see that indicated here. This horse has actually got coffin joint arthritis and osteochondral fragmentation as well. We have a normal collateral ligament, a slightly moved image, but a real world situation, and a fairly abnormal collateral ligament of the distal interphalangeal joint on this side. The top image here indicates a horse that's had a previous solar trauma, and this is a septic osteitis of the distal phalanx. Actually, this is an abscess within P3 itself. So a nice variety of lesions, and really they're quite satisfactory to look at, and really is illuminating to get this additional information, some of which we struggle to identify using other modalities. But one of the most important lesions that we're going to identify in MRI, and just to recap a little bit about MRI before we move on to CT as our comparison, would be deep digital flexor tendinopathy. So we can break these down into a number of different lesion types, which vary as illustrated from mid-substance or core lesions through to dorsal border lesions, which are of particular concern within the navicular bursa. Parasagittal splits, which can be complete, incomplete, multiple branching, and insertional lesions. And of course, many horses will have a combination of these, and they may vary as we traverse through from the pastern down into the foot, proximal and distal to the navicular bone. Some nice studies as indicated at the bottom here, and this is just several looking at some features on MRI of horses with deep digital flexor tendinopathy that are indicative of a negative prognosis. And of course, understanding the prognosis really gives us that ability to guide our owners, our trainers, and the treatment of our horses through this process, because often it is a long, laborious process of an awful lot of TLC and management. But if we know what factors potentially influence that in a positive or negative way, and these are ones that influence it in a negative way, then we can try and avoid those. So, for example, deep digital flexor tendon lesions greater than 3 centimeters in length, involving more than 10% of the cross-sectional area, that are by morphology complete splits, core lesions, or horses with identifiable adhesions, definitely have negative prognostic indicator markers attached to them. Likewise, a long duration of lameness, and that won't be a surprise, of course, if we've had a lesion that's been sat there, potentially erupted and burst into the navicular bursa, had time to cause a long-term inflammation and navicular bursitis or form adhesions, then managing that, picking up that case some months or potentially years down the line and trying to reverse or change that process becomes very tricky. And then from a monitoring perspective, we know things like monitoring the signal alterations within those tendon lesions, particularly the mid-substance or core lesions over time, can be helpful. So the resolution of stir hyperintensity within lesions is definitely associated with improvement, and or the lack of resolution with a negative prognostic indicator marker. And what do these look like? The example I've given you before is a mid-substance lesion here. We have a separate mid-substance lesion here, and this is then progressing to having an additional dorsal border lesion. This is extending into the navicular bursa, and you can appreciate the outline of the bursa here is quite irregular. We have some bursitis. We have a separate lesion here on the right, so we can ignore a little bit of magic angle on the palmar surface of this ligament lobe, but what we can see is this quite large synovial mass sat within the dark, which is the synovial fluid of the navicular bursa outlined here. And we know that when we take these horses to navicular bursoscopy, these two images are matched. So this is the same patient. These form quite large synovial masses, and these can be, manageable and debridable from a bursoscopic perspective. And some work by Kerry Sherlock and colleagues at VetCT Equine a few years ago now, quite nicely summarized in the statement at the top. So the presence and severity of pathology in the deep digital flexor tendon macroscopically is well represented by the presence and severity of MR signal change. So we can be quite confident that when we're seeing these MRI abnormalities in the deep digital flexor tendon, that they represent gross pathological and histological change within the structure. Other common lesions would certainly include distal interphalangeal joint collateral ligament lesions, and I think a couple of examples that I've shown here, indicated with the red arrows, this hyperintensity within a thickened and disrupted in distal interphalangeal joint collateral ligaments. We can appreciate a thickening here on this right stir frontal image compared with the normal ligament on this side. This is an example I think we can all agree is certainly confirmatory of a pretty extensive collateral ligament lesion and potentially partial rupture. There are issues with confound interpretation of collateral ligament injuries, including magic angle artifacts related to the positioning and the orientation of collagen fibers within our magnetic fields. And we have to bear that in mind, but certainly something like this, we can be very comfortable and confident in our diagnosis. But of course, many of these lesions, and the majority, are distal to the coronary band, making access for other conventional imaging modalities, such as radiography and ultrasound, highly limited. Intraosseous fluid can be seen in a number of places, but one example can be specifically associated with navicular bone disease or navicular bone degenerative pathology. This is indicated in these images by this hyperintensity on this sagittal image within the navicular bone. We can see that's quite prominently located axially within the axial third of the structure. And then we have other signal alterations. This is a T2 star gradient echo sequence on the right. So we can see primarily fluid-based abnormalities, which can range from truly edema, hemorrhage, microfracture formation, all the way through to osteonecrosis and fibroplasia in the absence of structural change. And we do see that in the presence of structural change as well, an example being this navicular bone in the center. But this is seen in a horse with fairly advanced distal interphalangeal joint osteoarthropathy, where we can see this capsular enthesius roughening, joint distension, osteochondral fragmentation, and overall malformation of the articular surfaces. And when we're starting to look at these, and this is a standing low field MRI examination, we can start to appreciate that potentially this is quite a thin slice, high resolution image for that system's capabilities, that the articular cartilage layers, which should be nice and hyper intense in here, are quite heterogeneous, potentially thinned and irregular in their margination with some subchondral bone change. So we might have an indication, but certainly it's far from clear. Of course, we could extrapolate and think this is quite a diseased joint. It's extremely likely to have significant cartilage damage. Other types of lesions we might see, specifically relating to the navicular bone, would include quite large lesions, such as erosions of the navicular bone palmar compactor, and this is a really prominent example here. And of course, these lesions we are used to identifying on radiographs, and they're a very important lesion to radiographically document their presence for. But we must remember that they're frequently associated with deep digital flexor tendinopathies. This is just an example a little bit proximal to the navicular bone, where this lesion extends right up, and it tracks actually right up into the pastern region. So just because we have a bony lesion as a primary finding does not mean we are excluding soft tissue lesions, which have potential great relevance. Of course, in this horse, the deep digital flexor tendinopathy is unlikely to be the thing that alters the long-term prognosis. This is not the same horse, but just to illustrate what these defects in the palmar compact bone or the navicular bone, so the navicular bone being illustrated here in another horse with a palmar compact erosion. This is the deep digital flexor tendon, which has been reflected palmarly. You get these really long strings of absolutely solid tissue formation filling into the defects from the deep digital flexor tendon. We've got loss of fibrocartilage palmarly over widespread regions of the navicular bone, hemorrhage and inflammation and excoriation of the deep digital flexor tendon surface. So these lesions are really nasty, affecting the bony structures, but the secondary effects on the deep digital flexor tendon, and we can potentially play that chicken and egg situation out, are really not to be underestimated. The severity of pathology can be quite advanced, and these are problems to manage. But just to draw attention, we must be mindful that there are other reasons for prominent palmar compact bone change in the navicular bone, such as we see in this middle example. And this is a horse that's had a solar penetration. You can see the very faint tract here, staying from the frog sulcus through up to impact the navicular bone. So this is actually a horse with a slightly different process. This is a septic osteitis of the navicular bone, navicular bursa, and this has a penetrating lesion through the deep digital flexor tendon. So there are other reasons that we can see change in this area also. And we shouldn't forget the soft tissue. So I've mentioned the deep digital flexor tendon. We've talked a little bit about the navicular bursa, the navicular bone itself, but we see changes associated with the entheses of structure. So this is a horse with a really quite marked distal sesamoid and impar ligament desmopathy. We have osseous resorption here with quite prominent surrounding palmar compact bone change of the distal phalanx, with a really marked extensive fluid distribution within both the navicular bone and the distal phalanx, and we can see that irregular osseous resorption and hyperintensity at the bone ligament interface here. So this is a horse with a really severe distal sesamoidean impar ligament enthesiopathy and desmopathy, as well as other changes being notable. MRI is really guided us, and this is looking at high field MRI, but MRI is really guided us an awful lot in understanding what navicular bone changes relate to, and particularly anatomically. And I guess for a long time, many people would have felt that the distal horizontal border synovial invaginations principally relate to navicular bone pathology and solely that. And I think we know now that these really strongly relate to the distal interphalangeal joint. In fact, if you look, they actually infill with synovial fluid from the distal interphalangeal joint, not related to the navicular bursa in the majority of horses. And so when we're assessing these distal horizontal border synovial invaginations on radiographs, and we link that back to MRI, we now know that increasing the number of distal border synovial invaginations has an association with an increased score or a more abnormal distal interphalangeal joint. We also know that an increased size of those distal horizontal border synovial invaginations is associated with a higher distal interphalangeal joint and navicular apparatus score when the cross-sectional area of the synovial invaginations is increased. And we also know, and for a long time, the shape of synovial invaginations has become of great interest to many people, or particularly boring to others, that the shape, such as these lollipop-shaped synovial invaginations, were associated with a higher grade of distal interphalangeal joint and navicular apparatus pathology than those that were simply present as linear synovial invaginations, so small and rounded linear distal border imagination. So there's a number of things we can take away from that, but primarily that synovial change in the distal border of the navicular bone is probably more associated with the distal interphalangeal joint degenerative conditions than navicular apparatus alone. I touched briefly on bone marrow lesions or interosseous fluid of varying descriptions, and this is just a consequence of a number of different sequences of the horse I showed you earlier. On the left, we have a T1 weighted gradient echo sequence where we have these areas of low signal intensity distributed throughout the middle phalanx with some signal alterations in the distal phalanx as well. T2 star corresponding image in the middle. So these regions of high signal represent the presence of fluid with an artifact surrounding them called phase cancellation or fat water cancellation artifact at the junction between the synovial interosseous fluid, I should say, and medullary fat. On the stir image, so this is a fat suppressed image, we lose the signal from fat, so the normal interosseous structures go dark, and anything that remains hyperintense represents fluid presence. Again, the etiology of that exact fluid type is not specific. You can see synovial fluid here filling the distal interphalangeal joint, but these are what we now term bone marrow lesions or bone edema type lesions, so fluid of varying distributions. Again, this is the same horse that has osteochondral fragmentation and osteoarthropathy of that coffin joint. So MRI really gives us an awful lot of information about varying conditions. I touched on articular cartilage changes and just a couple of example images of a horse with, and this is actually under general anesthesia, a really severe articular cartilage loss in the distal interphalangeal joint, where we have this loss of signal from the cartilage layers on P3, opposing that on P2, abnormal widening of the articular space. Equally mimicked in this image on the right. We can see the synovial fluid distribution is really uneven throughout the articular space. But note, when we have severe articular cartilage changes, the underlying subchondral bone and the cancellous bone within the adjacent structures really demonstrates quite marked abnormalities. And that gives us increased confidence if we're seeing these sorts of changes that what we're appreciating at the articular surface level is likely real. And that then comes back to what's been described in cadaver specimens, both from a number of different studies, back from Julien Olive a little while ago now, looking at creation of full thickness defects, small partial thickness defects, and linear partial thickness defects that showed us quite nicely that large full thickness defects we ought to expect to be able to identify on MRI examinations, whereas actually the sensitivity for detection of linear partial thickness tears is very low, and we should be rather skeptical. So we have to be a little bit careful there. A couple of more recent articles. This is a figure taken from the article on the left from PLOS One, demonstrate the effect of having the weight-bearing horse and the non-weight-bearing horse. Of course, this will come as no great surprise. As soon as the horse bears weight, we squish the articular surfaces together. We distribute synovial fluid differently, which gives us a lack of tissue contrast between the opposing articular cartilage layers. But also what we know is that the cartilage layers are truly physically sort of squished down, they're thinned and narrowed in the weight-bearing horse. And of course, the true spatial resolution of the imaging systems may limit our ability to see these fine anatomical structures and assess them in detail. So some caution is noted by these authors in interpreting articular cartilage in weight-bearing limbs. And it probably also is important to recognize that the position of the horse within the standing magnet, such as a wide or narrow base stance or uneven weight-bearing gait or stance, will massively affect the appearance of the articular cartilage layers and the joint fluid distribution. So we've got to be really mindful. And then a really interesting paper from the team at the University of Edinburgh looking at naturally occurring cartilage damage in the equine coffin joint on low field MRI and MR arthrography. Just a broad summary point here: the accuracy of articular cartilage detection was 0.63 or 63%, sensitivity of 14%, and a specificity of 92%. So really sensitivity rather poor overall. So we need to be really aware of that and trying to think, okay, are there other ways that we can evaluate these regions that may be better? And of course, a lot of this applies to low field MRI examination, and I'm not really talking too much about high field MRI in this part of the talk. And finally, just when we're going to compare onto CT, just an example of a hoof wall lesion, such as a keratoma. So we have this area of signal void here with this indentation in the parietal surface of the distal phalanx. We've got this loss of signal here from the resonating dorsal hoof wall layers, and this linear region of signal void within the hoof wall representing this keratoma in one horse patient. So this image is just a map taken from Hallmark's website, kind of documenting the distribution of their standing MRI and CT systems, and really to demonstrate that nowadays there's a huge variety. And this is simply just one manufacturer's systems, and this is primarily horses undergoing standing, or this is horses undergoing standing imaging. So of course this is then going to be added to significantly with the availability of different manufacturers' systems, MRI and CT, and those for horses under general anaesthesia as well. But when we look in the UK, there's a really wide distribution, and likewise in Western Europe, of these systems available throughout the region for our clients. And certainly there's no shortage, and this makes it really accessible from a practical standpoint of getting horses to MRI or CT systems. This is us here, where I'm talking from you for you tonight from Rainbow Equine Hospital. This is a photograph of the North Yorkshire countryside, in case any of you fancy a trip over to come and spend some time in the beautiful Best County in the UK. And now let's get on to the nitty-gritty of what about CT. This is kind of what we're talking about. So we've recapped what we can see in broad terms on MRI of the foot. What about CT? How does it stand up to MRI, which has been considered for a long time the gold standard antemortem test for foot lameness? I liken it to a little bit of a clash of the titans. Some of you may be familiar with the Avengers series, and it's almost a bit like two superheroes fighting against each other. You've got to pick your side, and a big part of that will be about availability of the test. We might think about MRI as the historic gold standard, but if you don't have MRI available, then CT is. We have to readjust our expectations. And if you have both, then you're really lucky. So let's try and pick out the cases and see perhaps which we should be shooting towards, one modality or the other, and compare how they perform. I'm a big CT proposer. I think it's a great bit of kit. This is a couple of examples of horses undergoing CT of different regions at our hospital from a little while ago, demonstrating the versatility of the technique to acquire images under general anaesthesia. So this is a fan beam CT system, tarsus, stifle, and some things like some starflithograms and pelvic imaging. So it's a really versatile tool, primarily because of the size of the bore of the gantry, so you can fit a lot of horse in this region. But there are some specific benefits to CT that really we can counter to MRI. One of the most important ones from an acquisition perspective is it's a really rapid test. So acquiring CT images of horses is typically a very short process. So scanning a 30 to 60 centimeter field of view might take less than a minute, whereas to scan that 15 to 20 centimeter region of anatomy with an MRI scanner may take in excess of an hour. So from a user's perspective, that might be quite attractive. Of course, it's also based on ionizing radiation, and a lot of us are very comfortable looking at radiographs, and so it becomes a bit more intuitive to those that are not trained in MRI interpretation, and it's a bit just more straightforward to get our head around. CT really does also, with certain systems, allow us the ability to image medium or larger fields of view than MRI without great complexity. So, for example, under general anesthesia, it's not a particular anatomical problem to image the foot to the stifle in a horse in a rapid period of time, or in the standing horse, a foot and a fetlock in less than a minute. Whereas, as I say, to do that under MRI conditions is either impossible or going to take you many hours. CT is also, almost irrespective of the system that you use, associated with extremely high spatial resolution. So our ability to resolve very small objects, and particularly things like small osteochondral fragments, little bone chips, and things like fracture planes, will be exquisite in comparison with MRI, where our slice thickness and our pixel or voxel size is often quite considerably thicker. In some systems, up to 5 or 6 millimeters in slice thickness, whereas with CT, we may go down to submillimetric slice thicknesses. And we can combine a non-contrast or plain CT with the use of contrast media, and we can give that contrast media in lots of different ways: intra-articular, intravenous, intra-arterial, intrathecal, intrabursal, using fistulography for draining tracts, or rely on the hoof wall. So there's an awful lot of ways that we can enhance a non-contrast or plain CT to give us more information with some more versatility and ease than potentially we can with MRI. And we don't have the same limitations with metal. We can image with probes in situ. We can image horses with foreign bodies in place, or with metal that cannot be removed. And things like 3D reconstructions to demonstrate lesions to owners, understand things in 3 dimensions for surgical planning, can be done rapidly on freely available softwares, such as the images on the right with a horse with a dorsal hoof wall lesion and distal phalanx osseous resorption. And this is quite nice for an explanatory perspective to our horse owners. And we can do these things pre, intra, and post-operatively, or even in combinations of those things if we want to monitor lesions of things like fracture fixation. CT provides a really rapid way of undertaking that. And just because we're considering which test doesn't mean we have to do one exclusively. So we could combine CT with MRI to potentially make the best of both worlds, from high spatial resolution bone imaging from CT and the potential for soft tissue imaging with MRI, though we'll come back to that again. There's a nice paper from Christian Byrne and colleagues, also from Scotland at the time, looking at the image quality of various systems when imaging the equine foot, and they found quite significant variability in the quality of the scan acquisitions that was obtained. This relates to MRI, but presumably we can apply the same principles to CT, and we'll have a little look at that as we move through. So the quality of your images is going to relate to the type of acquisition, the type of system you have, but also the patient compliance, which is a massive, massive feature. And that will again vary from standing to horses under general anesthesia. So let's talk through some CT options, what is available and how maybe we decide. And I'm not proposing one system over any others. I'm just going to give you a variety of systems that might be out there. This is a CT scanner. This is a fan beam CT. This is what we have in our hospital at the moment. This is a GE system, as is commonly used in human medical imaging, demonstrating a horse having a foot scan under general anesthesia in lateral recumbency. And these can be quite a nice system and quite an affordable system. Another option is the system marketed by Calibra. There's a horse, hopefully you can see this video playing. Please do let us know if these aren't working. Having standing fan beam CT examinations of the distal limbs. And this is a really nice system and allows for examination of horses' forelimbs, quite up to the level of carpus and tarsus, and hind limbs, sort of tarsus distally, as you can see in these images. What you can also see in this image in a second as we kind of move through regarding the hind limb is that we're still faced with the problems of patient movement. As if you just watch this video, it's just stolen from YouTube, and you can appreciate this horse's foot's moving as we're scanning. So imaging standing horses is never going to be straightforward, and we're always going to have to fight with movement. But if you look at the images that are generated by this fan beam system in the standing horse, I think they're really, really quite pleasing to the eye. Another option is moving through would be the Asto CT, another standing CT option. This is a system where a pair of fore or hind limbs are imaged at the same time, and quite a nice claim here. So a specific imaging diagnosis for lameness was achieved more frequently with CT, so 99% of the time, than with planar digital radiography, so 45% of the time. What I took away from that, mainly, if I'm honest, is that planar radiography has a hit rate of about 45% in this one series of horses. So if we're looking at our foot radiograph caseload, or fall limb lameness caseload, that having solely radiography, perhaps in more, 55% or so of the cases, we're not achieving a definitive diagnosis, or the same definitive diagnosis that would be achieved using a CT examination. And it's quite a brief examination here, so they document 15 to 40 minutes procedure times in total, which I thought was quite nice. And then we can move on to some really fancy options. So this is the system at Penn State Newborn Center, again from on YouTube, demonstrating the use of robotic CTs and tomosynthesis to image a variety of regions, including the foot in the standing horse, as exhibited here. This is based on a cone beam system and a flat panel detector. And using robotics that are probably more familiar to us in the automotive industry. Really nice, novel system, but potentially might be something that has financial implications for accessibility for many practices. The Medtronic O-arm, this is images taken from a paper by Fred Powell's, and also some corresponding radiographs and CT orthographic images on the left here, demonstrate another standing imaging option for imaging the distal extremity, and that might be a viable option for some people also. Also quite mindful in some of these images coming from the UK, myself, that we have to be super careful with radiation safety, and of course being very mindful of people being present in the room for these examinations, and being as limited as possible. Recently, Hallmark, who've kind of sponsored this talk this evening, have launched a cone beam standing CT system as depicted in these photographs for imaging feet and fetlocks of horses, fore and hind limbs. This is a schematic on the left, and just a video I just taken of a horse having a standing fetlock scan for illustrative purposes on the right. These are a paired concentric ring system, a flat panel detector and a cone beam radiation source. So radiation source here, and the detector on a smaller concentric ring in the center. It does a complete rotation around the limb in a minute, and this is again another system that has a really short acquisition time. Horses are in and out in 5 minutes or so for a pair of feet if they're quite compliant, 10-15 minutes if they're not, and another potential option available. So what are the differences? I've mentioned a few times fan beam and cone beam CT, and I just wanted to come back and circle on to this because there's a number of factors that you might want to be mindful of if you're considering CT, and these primarily relate to practicalities of use and image quality. So fan beam CT acquires images in a spiral. So think about a DNA strand, and the patient moves through along that DNA strand sequentially, and they're typically under a 3-phase power supply, so really high power output, high MAS, if you're thinking compared to radiography, and really have the ability to assess bony structures and soft tissues with really nice detail. Cone beam CT systems are, as you can see from the picture, acquiring, rather than slice by slice or in a continuous slice format, acquire a 3D volumetric data set in a complete rotation. One of the advantages of that is that the spatial resolution, the ability to resolve small structures is potentially very high, and there are some extremely high claims in some systems out there about the spatial resolution for cone beam CT, and certainly to some extent that is true. But what you often find is that many cone beam systems come and can be plugged into a normal plug socket, a normal outlet socket on a wall. They're low power systems. And so you find that the signal to noise ratio is typically, worse than with a fan beam CT, simply because the MAS is lower, and so that has a big bearing, as we'll see, on the ability to resolve primarily soft tissues. Cone beam CT is also quite prone to image artifacts, and we have to manage those in the way that we reconstruct those images. So there's some pros and cons, but cone beam probably would have the biggest benefit of being easily installable in most settings with simply a wall socket, whereas fan beam CTs, you're going to need a big 3-phase power supply and a bit harder to move around. What does it mean on the ground? So this is just a pair of images on the top left taken from a fan beam CT, the settings displayed below. So we've got a sagittal reconstruction on a bone algorithm and a soft tissue algorithm, where we can appreciate the osseous structures, the trabecular detail here. And then on the right image, we can see the deep digital flexor tendon coming down over the navicular bone. You can appreciate hoof wall and hoof capsule layer definition. On the right, this is a standing cone beam CT image. This is from our site. We have both systems available, the fan beam and the cone beam system. This is, again, a bone reconstruction and a soft tissue reconstruction. And from a bony perspective, I think we can appreciate all of the trabecular bone detail that we may want to identify, probably where we struggle. And this is primarily because of the low power output settings that come inherent to this type of technology, is with the soft tissues. We struggle to resolve as nicely the hoof capsule and the tendon and ligamentous structures in the foot. And this is a benefit over MRI when we think about fan beam CT in particular, but cone beam CT in a partial way, is that we can appreciate imaging the entire keratinized external layers of the hoof capsule. So on MRI, these regions would classically be signal void. We can't actually image them at all. We can't see this region unless we put an outer coating on the hoof capsule, such as a damp bandage, or apply something like some lard to the surface to give us a source of fat or protons to appreciate the outside hoof of the hoof capsule. Whereas with CT, we're looking for things like hoof capsule laminitis sort of changes, keratomas, mass-like lesions, abscesses, that sort of thing. We can appreciate all of the hoof capsule layering right to the very periphery. So that alone is a specific benefit that CT has over MRI for us. And as I mentioned before, we can complement CT with the use of contrast medium. We'll detail a little bit more uses as we move through, but this is just an example of what I mean by that. So these are the same 3 slice matched images of the same horse. We have a plane scan on the left, which is reconstructed in a bone algorithm, so looking at trabecular bone detail for a nice sharp algorithm. In the center, this is primarily detailed for soft tissues, so we can appreciate a little bit the deep flexor tendon here. You can appreciate layering in the hoof capsule. And then on the right image, what we've done is, this is intra-arterial contrast media injected during image acquisition. And so this is all the vascularity coming to the distal limb, to the lamellae, the deep digital flexor tendon. So we can complement our plane scan with things like intra-arterial contrast. And this is typically done under general anesthesia in the majority of cases. There's a number of studies that really have sort of described the different ways of using contrast, and I've just drawn our attention to a couple, which are quite nice examples. So I've mentioned the use of intra-arterial contrast to help delineate soft tissues. This is an example of a tendon lesion. We'll come back to those in a second, but this is hypervascularity associated with a deep digital flexor tendon lesion in the foot. We have examples here of a normal distal interphalangeal joint arthrogram, contrast arthrogram, and then a comparative lesion here with a horse with articular cartilage, fibrillation, roughening, and partial thickness defects on the left, and the postmortem pictures are at the bottom. We can appreciate the extent of changes, perhaps surprising given the arthrographic appearance and what that looks like. But actually, when you compare figure A and figure B on this left panel, the changes are quite stark. And certainly that's a really, that's very useful information and quite definitive on the CT with the arthrography. One quite nice study, I think, that that has been also published is identifying some horses with communication between the distal interphalangeal joint and the navicular bursa at CT arthrography. So some of these defects actually track through, there's little defects within the distal sesamoid impala ligament communicating the distal interphalangeal joint, as illustrated here, with the navicular bursa. So we have to be mindful of that when we're thinking about treatment of horses with varying conditions. I guess primarily of concern would be synovial sepsis, that these communications can exist. And that's been documented, as I say, using contrast arthrography. So what about some specific cases of use of contrast media? The top image panel here is, this is a juvenile horse presented with a markedly effused distal interphalangeal joint, distal limb lameness, undergoing standing, actually general anesthesia for computed tomography of the foot. You can probably all appreciate we have this fairly prominent subchondral bone lesion right here, this loss of bone mineral attenuation surrounded by prominent regional increased bone opacity or sclerosis. In a transverse plane, we can see that's quite patchy, heterogeneous, but quite large, and in a sagittal plane here. The bottom panel is a contrast arthrogram of the same horse. This region is our defect that's represented by the subchondral bone lesion right here. But note, if you come back to the contra-axial, I suppose, glenoid region, you have this area of contrast media underrunning a large cartilage flap, and that's this kind of depicted in a transverse plane, this large cartilage flap. Contrast media filling both the articular surface and underrunning that. And again, this is in a sagittal plane. And the use of the CT arthrogram in this individual really demonstrates a lesion presence whereby I think we would not expect necessarily to see a lesion based on the appearance of the subchondral bone, the articular space width. Now, you may argue in this horse, does it matter having a second lesion on this side of the limb? And probably the answer is no. But what if this horse had not got a large subchondral bone lesion that was obvious on the plane study here, but solely had the cartilage flap and this osteochondrosis lesion? So, of course, that would be a possibility, and this we would expect to be a cause of lameness in this horse, and detecting that would be important. And again, that's where things like our arthrography would become very useful. And just to blow that up for you, we can see that cartilage flap here, which is the dark region, with the bright white being the contrast media surrounding that. Something that I won't touch on very long, but just to mention its presence for everyone to be aware of, is the use of dual energy CT. These are a couple of papers just documenting the use of dual energy CT to identify intraosseous fluid or bone edema or bone marrow edema in people, using two different energy sources, so two different KVP and MAS settings, or actually two different generator sources on a human CT scanner, where they can do very fancy subtractions looking at non-calcium and virtual non-calcium content in bone, and then mapping and doing a subtraction and looking at what's left being intraosseous fluid. So this example is colored image. So we've got an MRI image here where the bright signal is intraosseous fluid, the dark is normal marrow, a plain CT on the right. And actually, when you then map on, this is the subtraction from the dual energy normal bone is indicated in blue, and the abnormal bone where we have intraosseous fluid is indicated in green, and you can overlay those two on a digital subtraction image. So there is a potential, I did say at the start, that MRI is our kind of way of picking up bone marrow lesions or bone edema like lesions. But in the future, we may find in veterinary medicine that dual energy CT can be a way to help us do that, though it's not widely available yet. So some standing CT cases, just to look at them, and see what we can see in standing horse. This is some sequential images from the solar surface moving proximally from left to right, and then moving proximally from the sole up through the distal phalanx, with a horse with extensive hoof capsule abscessation going on a long time, unresolving for local treatment that would be expected to manage a hoof capsule abscess. And what we can see quite nicely is this tracks up the hoof capsule wall laterally. This is associated with a hoof capsule parietal surface region of osteolysis, which is surrounded by pretty prominent increased bone mineral density or sclerosis. But what would be, I think, quite a challenge to identify radiographically is the extent of axial involvement here on the opposing side of this distal phalanx wing. which is really quite heterogeneous and extensive. So one might be forgiven in this horse for thinking this may be a keratoma based on a defect on the abaxial surface, but actually when you start putting all of this change together, this is a horse with septic distal phalanx osteitis and secondary hoof capsule abscessation, so a little bit more going on than meets the eye. This is a video clip of another horse undergoing standing foot CT with a chronic hoof wall in the toe region swelling, intermittent abscessation. I'll just let that play through again. That are presented for CT examination. You can appreciate this had solar debridement, but not resolution. This is a standing scan, and this is a horse that had a spherical keratoma. These are the images of the keratoma, which shelled out quite nicely at surgery, removed from the toe region. So CT was particularly helpful for guiding the exact location of a solar debridement required. You can appreciate here, this is the previous toe region debridement that had been undertaken, but it allows a very localized resection and the avoidance of extensive removal of the horn tissue and loss of integrity of the hoof capsule. Of course, this lesion would be identifiable radiographically. There's no doubt in that whatsoever, but potentially being very confident about the extent of the lesion and the lack of need to extensively debride the dorsal hoof wall as well, for one instance, would be useful to know. Other things, again, coming through, primarily bony lesions. This is a horse undergoing standing CT for foot lameness. You can appreciate here, we've got some distal interphalangeal joint capsular enthesius change and articular soft tissue swelling, as indicated here. But this is a horse with an osteochondral fragment associated with a navicular bone, and they reconstruct quite nicely in 3 dimensions to indicate what's going on there to owners. The radiograph corresponding to that's indicated at the bottom here. Of a horse with a chronic navicular bone wing fracture. What you will hopefully all appreciate in comparison with some of the images I've already shown you is that the soft tissue is particularly important here, being the navicular suspensory apparatus and the deep digital flexor tendon and navicular bursa, where we do struggle to evaluate on cone beam CT without further ancillary techniques. So from a bone imaging perspective, it's really nice, but there are some limitations, though it's quite nice to be able to do this in 60 seconds. And of course, sometimes you just need to prove a point to the extent of pathology, to an owner. This is a horse with chronic forelimb lameness and obvious navicular bone osteolysis radiographically, with disruption of the palmar compact bone, as we can see here. But what sometimes can be easy to underestimate is the extent and presence of osteochondral fragments, and actually truly the amount of structural change to that navicular bone with our planar imaging tests. So sometimes it can be used to identify the lesion presence, sometimes it can be used to confirm a lesion extent as well. Another example of another horse with chronic forelimb lameness. There's a little bit of a theme here, a fairly marked examples. This is a horse with partial collapse of the articular space of the distal interphalangeal joint. You can see that by loss of articular width here compared to the proximal interphalangeal joint. And that spans from lateral here all the way through to the medial glenoid. We've got significant alteration in the bone mineral density surrounding that. But look at the extent of soft tissue or dystrophic mineralization that's appearing in the tissues surrounding this distal interphalangeal joint, which we get the impression of dorsally here and a little bit palmally. I think in this horse, it would be fairly safe to say we don't need a contrast arthrogram to identify the lack of articular cartilage. But in terms of pre-surgical planning, understanding the extent of change and what's actually left there to try and do something about, the CT provides additional information on top of what you can glean radiographically. A slightly more mild example, just to illustrate a little bit some of the other changes that we see with distal interphalangeal joint osteoarthritis, is we've clearly got osteophyte formation on the margins of the middle phalanx here, on the navicular bone here. But some of these osseous changes associated with the dorsal aspect of the middle phalanx really span from medial to lateral around the margins. And on our 3D reconstructions, we can quite nicely show that all spiculated bone formation that we see here is not necessarily associated with the articular margins. We've got these little ridges that we often identify radiographically. There are attachments of the distal interphalangeal joint collateral ligaments. This bony change here is all associated with the distal interphalangeal joint capsule. and chronic synovitis. And then we've got all of this osseous change here, which is associated with proximal interphalangeal joint osteoarthritis, which is concurrently present. So just getting a comprehensive assessment of exactly what's going on allows us to know that, firstly, we don't just have distal interphalangeal joint osteoarthropathy, we also have proximal interphalangeal joint changes, but exactly what we're seeing structurally from a bony perspective. And the same changes we see in the proximal interphalangeal joint. So articular space narrowing can be nicely assessed, subchondral bone defects or hypodense regions within the subchondral bone that extend into the underlying epiphysis or cancellous bone. These are often really, when they're this sort of small size, can be really tricky to identify radiographically. Things like this, you just see a slight roughened contour to the subchondral bone surface. And little indentations like this, there's very likely significant diffuse articular cartilage loss. Obviously, this is a spectrum of pathology, and this is a really quite marked example, as illustrated by the extent of proliferative bone. But these changes all start somewhere, and potentially identifying these cases at a much earlier stage, if we can pick up these subtle subchondral bone defects really early in that process, might allow us to manage that horse in a different way through that period of lameness. Having pretty big welfare implications if we can use that technology that way. So I just wanted to compare the appearance of standing CT, as the last couple of images have shown, with some examples of horses undergoing CT under general anaesthesia, where we revert back to the higher output fan beam systems. So this is another horse with proximal interphalangeal joint osteoarthritis, similarly with fairly large multifocal osseous cyst-like lesion formation, pretty extensive, and a really deformed proximal interphalangeal joint, pretty nasty osteoarthritis. And actually, whilst this system results in a much larger radiation dose for the patient, and there's an awful lot of information regarding trabecular bone detail here, I think in this instance, I would feel very comfortable making the same assessments that we've made on lesion morphology, structure, size, extent, and so on a fan beam system as I would have been on a cone beam system, which we could have done in the standing horse. So that's quite reassuring and quite nice. I don't think we really glean an awful lot more information from having anesthetized this horse than we would have done standing. But CT, in comparison to MRI, can be particularly helpful in horses with foreign body presence. Things like this is a horse that's had stood on some metal and that's been removed, but we've got large fragments of metal remaining within the hoof capsule close to the distal phalanx, for which the extent was quite tricky to determine on radiographs. Mapping exactly where that lies in 3 dimensions in relation to the margins of P3 can be quite tricky. In fact, you can see this is the non-ossified palmar aspect of the collateral cartilage of the foot, and we can see that lesion tracks up quite proximally orientated towards it. So clearly this is a horse that we could not put in the MRI and expect to see anything useful from an image quality perspective. However, CT provides a really nice way of evaluating where does that tract go, what's our orientation, how likely are we to involve any synovial structures, is there any underlying osseous change in P3, and then guide specific local treatment. And I mentioned the use of probes and fistulograms, things like that. So this is a horse that has clinically signs consistent with quitter, so a chronic draining tract over the lateral aspect of the proximal coronary band. It's a hind limb. And so through that draining tract, you can place something like this. This is a sterile wound probe into the tract, and so also diagnostic anesthesia performed, or therapeutic anesthesia performed, just to be comfortable and stand. And then with that probe in situ being a tiny little fine metal probe, you can then scan that horse and identify that tract, which extends right down into the hoof capsule. This is our navicular bone here. This is the wing of the distal phalanx here, and that probe comes all the way down through, right down to the distal phalanx. And we actually got a solar abscess right down here underneath the margin of the distal phalanx. So identifying that tract extent is absolutely vital to guide specific treatment. You can actually see here the margin of the non-ossified cartilage of the foot is abaxially displaced with this soft tissue swelling, but actually this is a tract that's minimally involving the cartilage of the foot. We would have considered this a classic quitter, but in actual fact it was not, and this tract ultimately involved the distal interphalangeal joint and chronic sepsis. So talking a little bit about contrast is great, but we can identify some lesions in the soft tissues using fan beam CT without contrast media use. So this is just an example of using these soft tissue algorithms and reconstructions to look at deep digital flexor tendinopathy. identifying things like navicular bursa, margination and effusion as this dark band here. And then looking at deep digital flexor tendon lesions themselves, we can see these regions such as this hypodense area within a swollen tendon lobe, examples here and here with this roughened dorsal surface and surrounding fluid distension. So non-contrast CT can be very helpful to identify large mid-substance tears, but really for other lesions, we do recommend the use of contrast media. So this is a horse. I'm going to show you some more images of this horse in a second, which presented with concerns regarding navicular bone and navicular apparatus pathology on radiographs. And when we look at this navicular bone, I think we can safely say this is an abnormal navicular bone structurally. We've got these large, sort of partially cystic appearing or lollipop-shaped synovial invaginations, roughened sloping borders, elongated and roughened proximal borders. And we've actually got opposing lesions on the margin of P3 here from chronic remodeling. You can appreciate that again here. So we take the same horse and then inject intraarterial contrast media. This is done under general anesthesia, and just look at some reconstructions. This is a large area of hypervascularity or neovascularization along the dorsal sort of swollen surface of the deep digital flexor tendon. You can appreciate that region here. This is the deep digital flexor tendon in the pastern region, coming down to the navicular bone. And we've got this contrast enhancement or hypervascularity along the dorsal surface. So this is a significant dorsal border deep flexor tendon lesion. And actually the same horse, as we move a little bit further distally, has this really marked area of hypervascularity within the opposing deep digital flexor tendon lobe, going right down over the navicular bone. And this is really quite severe contrast enhancement or neovascularization. So when we look back and reflect on this case, yes, the horse has got significant structural change associated with the navicular bone, including a little bit of palmar surface irregularity, but actually we have a really quite marked and relatively extensive soft tissue, namely deep flexor tendinopathy, which is quite likely to be a significant feature associated with the lameness in this horse. So we have to look beyond the obvious. Just another example here of another horse with, again, the non-contrast bone reconstruction, soft tissue reconstruction in the middle with no contrast, and then the intraarterial use of contrast media to identify more deep digital flexor tendon lesions in the foot. So we have this roughened dorsal surface of the deep flexor tendon here within an effused but quite heterogeneous navicular bursa. When we inject arterial contrast, we see this hypervascularity of the synovium. We see this prominent hypervascularity associated with the dorsal surface of the deep flexor tendon. And then we start seeing this hypodense region within this lobe of the deep flexor, which on slightly further imaging has this peripheral or rim contrast enhancement. So this is in essence a core lesion or mid-substance tear with an overlying dorsal border lesion within the navicular bursa. So the lesion is visible on the non-contrast scan, but it's certainly more prominent or more conspicuous on the post-contrast sequence. So really CT is with contrast here quite invaluable at picking that lesion up. So one thing I'd probably just draw everyone's attention to is a couple of articles looking at the use of contrast media, some really nice reads, and a few features that we should be aware of. A large number of lesions occur proximal to the navicular bone, and those lesions really nicely are identifiable on contrast enhanced CT. You're looking at a rough sensitivity for diagnosis of deep digital flexor tendon lesions of about 93% compared to histology and MRI. So that's pretty high, pretty pleased with that in general. However, what we do know is that lesions distal to the navicular bone in particular are really quite a little bit harder to identify on contrast enhanced CT and probably are more applicable to being an MRI diagnosis. But actually MRI, in contrast to CT, does somewhat struggle to allow us to pick up subtle dorsal border abrasions, which we might appreciate with the use of contrast enhanced CT a little bit more straightforwardly. So as depicted in the image in the center. So there's a bit of conflicting evidence, but I think we should not write CT off in any meaningful way for the use of identifying deep digital flexor tendinopathy in the sort of sesamoidean and suprasesamoidean regions of the foot in our equine patients. And how do we do the intraarterial contrast? Just in case anyone was unsure, what we tend to do is place an arterial catheter in the medial aspect of the limb, just at the level of the chestnut, proximal to the carpus, and ultrasound guidance. These are fairly straightforward arteries to get access to in the forelimb, and typically in the hind limb. For comparison purposes, we place arterial catheters dorsolaterally over the distal tibia. and inject contrast media using a power injector, ideally, and injecting from a safe, as in radiation safe space throughout the time of acquisition, and that's a fairly straightforward technique. Getting towards the end of this talk now, and just wanted to summarize a couple of other things where CT's got some specific additional uses over MRI, and that would be in the detection and sort of understanding of foreign body presence in the foot. So there's a nice article from the University of Liverpool not so long ago now, looking at various different foreign body materials placed, slate, plastic, glass, wood, and actually soaked wood as well within the sole. And CT really scores quite highly, particularly in comparison with other imaging modalities, for the identification of these foreign bodies. Certainly, depending on their sort of depth and extent within the keratinized tissues in comparison with the sort of deeper resonating soft tissues. Lesions within the keratinized hoof wall would potentially be a real challenge to see on MRI, because we don't get an awful lot of signal from these regions anyway, and until they extend into the deeper tissues, we may struggle to appreciate them. But actually, CT performs really nicely in just seeing and knowing what these different foreign materials look like on scans can, as illustrated by this paper, has been really helpful. So I'm personally quite a pro CT for foreign body detection, extent, and understanding of orientation. And we also sometimes use CT for pre-surgical planning. It's quite, I've mentioned before, it's a rapid test in a majority of cases, and particularly being able to do that standing. I'm not necessarily advocating in this individual with a fairly large proximal phalanx osteocyst-like lesion surgical intervention, but targeting that and understanding, being able to place surface markers such as staples, metal ball bearings on the limb, and scan with us in situ to orientate surgical apparatus to guide ease of intervention for our surgical colleagues is a real potential benefit. And being able to do a scan, understand the pathology that's present, place some skin markers, do another scan, and 60 seconds later be able to check that the orientation of your entry and exit points for surgical intervention are exactly where you want them to be. Another example here for a distal phalanx fracture, and has been described recently in 51 horses, is a massive potential benefit. And the short acquisition time really does make that an easy process for the teams to undertake. So I quite like the use of surface markers, such as the little ball bearings or skin staples. Can use barium paste and other things as well. Often tends to dribble down the leg a little bit, unfortunately. But that's sort of another guidance for internal fixation or the surgical treatments can be helpful. And likewise, it can also be useful to identify location of foreign bodies, depth, tracks of solar penetrations, and that sort of thing. So to finish up, what about comparing modality? So I've just got a comparison standing cone beam CT of a horse with forelimb lameness, and hopefully what you can all appreciate here is a hypodense plane traversing in part the wing of the distal phalanx. So we're seeing this lesion in a horse. There's fairly pronounced increased bone attenuation surrounding that, so it's chronic. There's clearly a lot of chronic osseous remodeling here, some resorption. I think one of the key things here is we can see structurally there's a lesion present. I think that would be challenging in part to quantify radiographically. So CT is going to give us an awful lot of information that we wouldn't be happy making decisions on from a set of radiographs. And there's not another, ultrasound's not going to help us here. But what do we know about activity of this? And this is probably a downside of CT, is determining activity of bony lesions is really tricky. This horse's MRI examination. Again, we can appreciate our incomplete fracture, the pronounced surrounding increased bone mineral density, and a couple of different orientations. But actually, this is really chronic and fairly quiescent, and there's minimal fluid-based signal surrounding that within the distal phalanx. And this horse actually had a collateral ligament injury, which was marked and active, and was much more likely to be the cause of this horse's lameness than this chronic change. So potentially combining modalities might, in an ideal way, I suppose in my humble opinion, be an ideal way of understanding things a little bit more. So you potentially combine the structural detail of CT, the high spatial resolution, with the physiological imaging of things like intralesional or intraosseous fluid presence or absence with MRI, and the ability to identify soft tissue injuries within all of the vital structures that we know we can do on MRI, and putting those two bits of technology together. I'm not necessarily advocating them have to be done standing, but of course these are equally applicable to horses under general anaesthesia. Just a couple of examples used here, but putting them together, I think, probably is the most sensible way forward, in my opinion, where finances allow. And that's kind of how we've tried to use them in a hospital setting ourselves. But if we have a pathology suspicion and perhaps, you know, for any reason, both modalities is not an option, how do I try and decide which way to send a case? And I've just kind of grouped the sort of big, broad lesions that we kind of come across in the distal limb or in the foot down the center. The red arrows are probably my strong comfort zone or recommendations as to which way certain conditions should go. I think fractures are a great example where CT can be a rapid, versatile test to really comprehensively understand lesions. Whereas, for example, soft tissue lesions probably, in the standing horse at least, you know, are a case to go towards MRI. Interest is fluid at the moment towards MRI. And some of the other changes we could potentially pick either. So, you know, osteoarthritis, osteochondral fragments, we could probably choose MRI or CT and feel fairly comfortable that we'd be able to identify and characterize those quite nicely. What we can do, depending on our availability of MRI or CT, is think, okay, if we've got this case and we're suspicious of a soft tissue lesion, how can we enhance CT to try and help us see that? So the use of contrast enhancement or contrast media. Do we need to be doing that standing or under general anesthesia? Have we thought outside the box with regards to how we can adapt the technology to really get the most out of it? Are we thinking about arthrography? Are we thinking about tenography? Are we thinking about arterial and vascular use? And that maybe helps us with our articular cartilage lesions, for which we know identification on either modality could be a challenge. So to conclude, I hope I've indicated a spectrum of use of MRI and CT and a little bit of how I feel about how we can use those modalities individually and together. In my opinion, should we use both of them more than we do, and just not from a commercial perspective, purely and simply from an equine welfare perspective? Absolutely, we should be, and where that's possible, we should be talking to our horse owners and our trainers about what that can tell us and how that might help us. Brainstorming some reasons and talking to our team about some reasons why we maybe think it isn't used a little bit more. Obviously, a big one is cost. We know these things are expensive, especially in the current world situation. Availability might be considered that, but actually showing some examples on the maps, I think there's a lot of places that are available and it's accessible, but probably a historic lack of clarity on what can be identified using the modalities. A lot can be identified if we just truly get outside the box and use these to the maximum. And I think we're in a place now in the world where there's a misunderstanding that rest fixes everything in some owners and trainers and vets' eyes, and we know that that's not the case. and then those horses that rest doesn't fix, perhaps medicating the joints will. That's fine if we're dealing with some degree of low-grade joint disease. But how many horses are having multiple rounds of joint medications that are having a partial effect, and actually the underlying problem is a soft tissue injury? And we need to be thinking about picking these up and treating those horses specifically for those lesions. So knowledge is power. Will CT replace for MRI? If I'm honest, I don't think so. MRI is just such a useful test, primarily for soft tissues, but I'll get the crystal ball out and we'll see. But I think potentially what might be quite interesting is, will CT at some point replace radiography and three-dimensional imaging replace planar imaging? And that's potentially quite an exciting space to be. And I'd love to get everyone else's thoughts on that. And on that note, I'm going to stop there. Thanks for bearing with me.
Thank you, Jonathan. That was a really interesting talk and lots of very interesting cases. It's really interesting to see how the Hallmark CT system and the other CT systems can be used. I don't currently have any questions. If anyone in the audience has any questions, there's a Q&A box at the bottom of the screen. So feel free to open that and type in any questions that you might have. I would just like to ask, given that you are lucky enough to work in a practice that has all three types of imaging that you've been talking about today. I was just wondering how you, clinically, make decisions as to which modality to use in your clinical practice. So if you've got a horse that comes in with a front foot lameness with nothing on X-ray, what would be your choice of modality for imaging that?
Yeah, and that's a really great question. I think that's the question that ultimately we don't have enough evidence base to make an absolute informed decision on at this stage. So what I'm personally moving away from the idea is that the first line imaging should be radiography, because I think, we know, let's say, just take the paper that I showed with the ASTO CT link, greater than half of those horses were not correctly diagnosed, just in that one group of cases with radiography, and that was not even comparing to MRI. So I think we are going to be left with radiography irrespective for a long time because of our need to work, the importance of working with other paraprofessionals, and not things like farriers. Not everybody will be happy looking at MRIs and CTs straight away, and so we probably going to need to keep that as part of our repertoire, maybe indefinitely, but certainly for a long time. But I think I much more rapidly move towards cross-sectional imaging as a general rule than I ever used to. I think you learn how much you don't know, and from scanning these horses, and certainly from scanning horses with both. I've been very lucky to scan horses with both modalities for quite some time now, thanks to some very kind support from Hallmark. And there's an awful lot that each modality shows you, but I think the combination of using them both is great. I guess horses for which I'm considering a soft tissue injury, most likely, I'm for sure pushing them towards the magnet straight away, and getting them in to have a standing MRI or a MRI under general anesthesia based on optionality. Horses that I think have sustained acute trauma, I'm concerned about a distal phalanx fracture, navicular bone fracture. Horses whereby I know they've got navicular bone injuries, structural navicular bone injuries. I'm not sure if I can determine if it has a flexor compactor erosion. I'm just a bit suspicious. I think those are great candidates for CT, just to prove the point, because if you have got a palmar compactor erosion, you can be very confident you're very likely to have a deep flexor tendinopathy as well. So if you have an option you can do rapidly, and for some sites at a much lower price point to clients, it makes it more accessible, then you can extrapolate that data out. And I think if you say, right, okay, we've got definite proof here in a minute, or in 5 minutes of acquisition time of a really severe lesion, almost certainly we've got soft tissue lesions. Does it matter how extensive that is? Maybe it does, maybe it doesn't. Probably the reality in those horses, it doesn't. So there's a whole bunch of horses with osteoarthritis, hoof wall lesions, keratomas, abscesses, laminitis, and primarily, in a limited way, navicular bone injuries, whereby I think they're suited towards CT in some format. Horses where that's just not the case, chronic low grade, intermittent low grade, soft tissue distension, pain and palpation of the deep flexor tendon or collateral ligaments on digital palpation. Those horses to me are still going towards MRI where possible. But I'm in Yorkshire in the north of England, and financially, and that will be the same for a lot of you guys listening around the world, that's not always an option. And CT is interesting from that side because it's a whole lot more information. And I suppose it's a bit of a wishy-washy way of saying I don't know, but I try and think what's my most likely differential and which test is going to pick that up.
Okay, that kind of leads nicely into one of the questions from the attendees about using the standing Hallmark CT system for imaging soft tissues. What are your thoughts on that?
I think it'd be fair to say that the technology is massively advanced in the last 2 years. This is new. You have to think back to standing MRI in 20 years ago of how it's changed from then to now. These technologies only advance over time, and I'm aware there's significant updates coming, which will probably have a significant impact on soft tissues.
Nick is actually in here with us, and I've just given him permission to speak if he wanted to jump in as well.
But I think currently, from a user's perspective, we without the use of additional ancillary techniques like contrast media, like things like bursograms rather than arterial or vascular use, I think it's quite limited. But I'll let Nick elaborate on future plans if that's helpful.
Yes, can you hear me?
Yes, thank you, Nick.
Yeah, I would strongly recommend MRI for anything soft tissue at this stage. I mean, technically there are possible ways to enhance the CT to improve the soft tissue. It will never be as good as the MRI. And you know what you've got now, what you've got for the next year, I'd play to its strengths. Use contrast if that's an option. Use MRI if that's an option, and wait and see what happens over the next few years as we develop new features and improved capabilities of the existing features.
Okay, thank you, Nick. I think that answers that question very well. And there's just a couple of final questions, Jonathan. One is about how accurate do you feel this hallmark standing CT unit is for detecting cartilage damage in the fetlock when using contrast? So I'm presuming we're thinking intra-articular contrast here rather than intra-venous or intra-arterial.
I'm not aware of anything published relating to that. And I think the biggest influencing factor that we have a control over in that process is going to be the amount of movement in the images. So we're imaging standing horses. That is a joint that is definitely liable to motion. If we're talking about things like race horses, we know they often stand very well for imaging in general. We know that from MRI and scintigraphy, and in general they stand very well, don't they? The majority of cases, but it's very, very motion specific. I think if you get a perfectly still horse with an arthrogram, I think, you know, if there's something like a full thickness extensive lesion, you know, you would want to be able to see that. But I think a bit like we've seen from the MRI studies in weight bearing horses, there's massive limitations with contrast distribution. The cartilage in the fetlock is very thin in general, so the resolution of that is tricky. I think the biggest issue is probably going to be weight bearing aspects for identifying the articular cartilage layers, in my experience. But you know, I'm conscious of other people on this call that may have different views.
I think from a publication point of view, it's very much a watch this space. I know there's quite a lot of work going on, looking at for sensitivity and comparing that with both fan beam CT and MRI. So I think that's work that's probably in progress at the moment that hopefully we'll be getting some results of relatively shortly. And just one final question, because I'm aware we've kept you all long enough this evening. There's just a question about the costings of bilateral foot CT and how that would compare to MRI. Obviously, it's a very clinic specific comparison, but just roughly proportionally, how much are you charging for a standing CT relative to an MRI, standing MRI?
Yeah, so that's a great question. I think can I answer that in two parts, if that's okay? One part would be standing imaging, and one part would be imaging under general anesthesia. And I'd like to sort of subdivide that off one bit further as well. So the standing stuff, I would say, is a guide compared with MRI, somewhere between a third and a half would be a fair guide of the approximate cost. I think for horses under general anesthesia, that becomes a bit of a different process, because we CT horses in our clinic under anesthesia in two different ways. One is a diagnostic process where they undergo general anesthesia, CT contrast, whether that's intra-arterial, intrabursal, intra-articular, and then we recover them, at which point that's a diagnostic procedure. And there's probably looking at something similar to the cost of a standing MRI, because there's a lot of time involved, a lot of materials that have expense themselves. And that is a guide. And then for horses undergoing something like a CT under general anesthesia for a fracture, let's say more proximal on the foot that you're considering repairing in theatre under GA, like a spiraling medial condylar fracture, something like that, for example, you're talking about a non-contrast scan on a horse that's undergoing a general anaesthetic anyway, going straight to theatre afterwards in a process that takes you 5 minutes. That's probably more comparable to a standing foot CT price in our hands, because I think you've got to balance the amount of workload, the amount of reporting time, the consumables used, and the fact that the horse is having a general anaesthetic anyway. You know, I'm a massive proponent of preoperative CT for a whole bunch of orthopedic conditions if it can't be done standing, because a non-contrast CT of a limb in our experience, it adds 5 minutes onto general anesthesia time, and provides a vast amount of information. It gets more complex if you want to do things like stifle arthrograms and so on, and that's obviously a different situation. But I think there's an awful lot you get from CT for joint disease, standing RGA, and my 2 cents worth.
Perfect. Well, I think that's about it for questions. So if that's everything, thank you. All that remains is to thank Hallmark very much for sponsoring this evening, and thank you to Jonathan and Nick for your contributions. I hope everybody has a lovely rest of day or evening, depending on wherever in the world you're joining us from. And if you have any questions, do please feel free to email me at VetCT. Thank you.